Can you see my shared screen now?
Excellent.
Okay. This lecture is a review of ankle arthrodesis in diabetic foot fractures. I will talk mainly about the primary indication for arthrodesis in diabetic patients. As we know, ankle fractures are one of the most common fractures in our population. So these fractures also are common in diabetic patients with an increased risk of complications. Owing to the increased local and general risks associated with ankle fractures in diabetes, many surgeons suggest that conservative lines of management are safe. However, it turned to be wrong over time because there is a lot of complications with conservative management, which may be end with Charcot arthropathy and amputation. We use many techniques for arthrodesis, primary arthrodesis methods in Charcot patients or ankle fracture patients, like retrograde talocalcaneal nails, Elizarov external fixation, internal fixation, or a combination of these techniques. We also depend on the concept of the superconstruct developed by Manway. This concept states that you have to apply rigid fixation, increase the number of fixation strengths and the mechanical properties, decrease the deep dissection, and you have to extend the fixation beyond the injury. So we mainly depend on using the internal fixation, combination of intramedullary fixation and plata screw to increase the strength, and also extend the fixation to the subtalar joint. So we extend the arthrodesis from the ankle to the subtalar, so we have a consolidation and solid fusion. How to choose the right patient for with the ankle fracture in diabetes for primary ankle arthrodesis? We depend on two scores, on the AFDA score and the Eschentoll's staging system. The AFDA score, which is the Adelaide fracture in diabetes ankle algorithm, and depend on points. We give points, 1 point or 2 points, according to the findings we see in the patients. For the diabetes history, more than 20 years, presence of neuropathy or retinopathy, obesity, or poor patient compliance, we give 1 point. For the peripheral neuropathy, loss of protective sensation, presence of vasculopathy, insulin dependent with poor compliance, and the previous history of Charcot arthropathy, we give 2 points. We calculate these points and they give a score according to each patient. For most of the patients with a scoring system more than 5, we proceed to primary ankle arthrodesis, because we know from the literature review and that these patients have a lot of complications with the internal fixation and may end with Charcot arthropathy. So we proceed directly to the primary ankle arthrodesis. For patients with a score less than 5, we may try the using of internal fixation and follow up the patient for any complications. The Eschentoll's scoring system also, we add this system to our clinical evaluation of the patients. It divides the patient into 4 stages, from the inflammatory stage to the fragmentary stage to the coalescence and consolidation. In the inflammatory stage, we see the local inflammation and the minimal findings in the X-ray. For this patient, we may proceed with conservative treatment versus internal fixation. For the fragmentation or coalescence stages, we may proceed to the primary ankle arthrodesis, and also if there is healing in the consolidation stage with deformities, we also proceed to primary ankle arthrodesis. I have a lot of literature review regarding this lecture. This paper, Primary Arthrodesis in Diabetic Patients with Ankle Fractures, they have their review of 13 patients with ankle fractures underwent primary ankle arthrodesis. They found that they have a complication rate 3-fold in more than the non-diabetic patient. About 40% of the patients have complications. These complications range from wound breakdown, deep infection, non-union, hardware failure, and Charcot arthropathy, which in some patients require repeated operations and may end in amputation. Their indication for primary arthrodesis, they mainly depend on the patients with high level end organ damage in diabetes, the risky patients. with nephropathy, retinopathy, neuropathy, peripheral vascular disease, as we see previously on in the AFDA score. The overall high complication rate, about 77% of the patients experienced at least one complication. Only 2 of their patients had complete consolidation. However, this high number of non-consolidation were asymptomatic. 10 patients were saved from amputation, and 3 patients has limb amputation. Another paper talking about the primary tibiocalcaneal fusion for high-risk complex ankle fractures. They have case study on patients with ankle fractures. They stated the same. They have a high complication rate of about 40%, nearly 3-fold higher than the patients with non-diabetes. They have difficulties and the complications from diabetes. They state that these complications from diabetes come from the hyperglycemic states, which lead to arteriosclerosis. Arteriosclerosis result in poor hypoxia and poor collagen synthesis and immune cellularity. Another paper talking about the primary arthrodesis for diabetic ankle fractures using a modification of retrograde femoral intramedullary locking nails combined with lateral plating and surgical techniques. This paper was published in April 2024, and it is conducted here in Egypt. They made a prospective study on 8 patients, but the only 6 patients were followed during the study. These 6 patients were undergone acute ankle arthrodesis using a modification of the retrograde femoral nail. They modified the entry of the anterior screws to be from the anterior ankle, from the lateral, not from the anterior, because it have a lot of complications. The average hemoglobin A1C on admission was 7.9, and the average AFDA score was 7. As we see, most of the patients above the 5 score. All the patients except for one achieved union at the arthrodesis site at an average of 10 weeks. They have 2 complications, one with deep infection and was treated by removal of the implants and the Elizarov. Another one have a broken nail and was revised with internal fixation. They put this scheme for their management technique. For the patient with fracture dislocation and with no Charcot, they require fixation. They first calculate the AFDA score. If it is below 5, they go for open reduction internal fixation. If it is more than 5, they go for primary arthrodesis. You see that it is the same. They all depend on scoring the fractures and arthrodesis for more than 5 scoring system. Another paper talking about the arthrodesis in the deformed Charcot foot. These patients with chronic Charcot foot or chronic ankle fracture dislocation, they go also for ankle arthrodesis. They do a study on 20 patients with ankle and high foot Charcot joint using a retrograde intramedullary nail. They have excellent evolution with a mean 90% of cases showing fusion. The most common approaches they use, the anterior and lateral approach, the transfibular approach. Another study from Devaris and the colleagues conducted a study also for treating more than 52 patients with deformed ankle, with ankle arthrodesis, and also the mean follow-up was 69 weeks. They have only 23% of the patient ended with amputation. You see, as you see, there is a diverse in the results from between the papers. We see some papers give excellent results, and another papers giving poor results with 23% amputation. The tibial arthrodesis with nails is a good strategy. They stated it in correcting and treating severe deformities of the ankle, and also they depend on the concept of super construct in using locking plates in combination with plate and screws. Take home message: tibial fusion is safe, effective in treatment for unstable ankle fractures with high risk diabetic patients. Although this primary arthrodesis may be considered, but the optimal patient and the injury type is not clearly defined. Care should be taken due to high complication rate in cases of primary ankle arthrodesis following ankle fractures in diabetic patients. Also, as we see, a lot of papers were published on these primary arthritis in patients with diabetic ankle, but the results are different between each paper. So we don't have, until now, clearly defined results for using this technique for treating ankle fractures in patients. Thank you.